So next is Ashish Patel. So we're looking at the safety, efficiency, and the prone lateral. Thanks.
Thanks for having me, everyone. Here are my disclosures. What's relevant to the talk is I'm a consultant in product development for Globus with their retractor system. So the core benefits of lateral and prone lateral remain the same. The idea is to perform a very wide annulotomy and disc release so that you can place a very large interbody spacer, and then apply indirect decompression so you can avoid the posterior elements dissect through the canal in order to reach the disc space. But it's been about 5 years since we reported on our initial feasibility study on PTP access, pilot study, if you will, and it won Best Paper at LSRS in 2020. So when we talk about the efficacy of prone lateral, it's quite effective. We went from single or one-level, two-level type surgery through the pilot study in order to understand, the potential benefits and issues, to now multi-level surgery, surgery involving osteotomies, add-ons, decompressions, to prone lateral corpectomies in the thoracic spine. The safety profile, there's been some study in the last couple of years, since there's been a few years now of prone lateral. Here's a study, meta-analysis of 10 studies. And you can see the list in the table below of complications, including aborted laterals, cage repositioning, possibly from the rotation that's needed in order to improve ergonomics. ALL rupture comes up frequently. But you'll see from the list that the complication profile is similar for prone lateral as it is for lateral. I think you need a few more years and more studying in a larger group to understand if there's really differences between the two. Here's another systematic review, 15 studies, 750 patients, no difference in complication profile between prone lateral and lateral decubitus. But we know that there's differences, right? There's positioning trade-offs here. When considering lateral, you have the table below, and that creates a stable base. And then gravity actually aids in keeping the retractor to the spine. It's very, very stable. You don't have any shifting. The issues or limitations are that you don't have access to the posterior space. You can do single position lateral, place screws. Decompressions become harder, multi-levels, osteotomies, all that becomes very difficult. And in prone, you do have access to the posterior space to perform that. And depending on your practice type, you may need these if you have a deformity-heavy type of practice. Not flipping the patient, that makes everybody happy, from the staff to the doc to the patient. There's some efficiencies there. But gravity is an issue, and the primary issue in prone. Gravity wants to pull the retractor ventrally and cause retractor dislodgement. So we published on our learning curve, first 150 patients. We identified the nuance and some of the issues with prone, more fat in the working corridor, ALL ruptures. Again, we had 3 in our first 30 cases. That's 10%. So it's an issue that you have to recognize and overcome. We were lucky we didn't have any bowel perforations or vascular injuries. That's a bad day. And so, we published on our tips and tricks to try to improve the workflow, educate people to some of these nuances around prone. But the 2 main things remained, which is, how do you stabilize the patient? How do you create retractor stability? All these things have to do with safety. So this was our crude attempt initially to stabilize the patient. You can use just tape, or you can use orthopedic bolsters on the other side. But as Michael had said earlier, there's these new patient positioners that are designed to sandwich the patient on both sides. So you have the ipsilateral bolsters and the contralateral bolsters. And that sandwiching effect does 2 things. It avoids the pistoning effect of the patient, but also if you're rotating the table away, it avoids the patient slipping away from you, which pulls the retractor out. There's an added benefit if you manipulate the legs or the hip that you can deviate the pelvis in the coronal plane. If you're trying to access, let's say, L12 or L45, you can also move the legs in extension to influence the sagittal plane. So retractor stability is the main other issue. After we had our ALL ruptures, we would place a fourth blade or ALL retractor around the front of the spine. That protected the vessels from our inner body work. This way, that's the lighthouse. You could always see the ALL. You know that your instruments, be it a carb or box cutter or whatever, would not perforate through the ALL, protecting you and avoiding the ALL rupture. But now, once you've docked, different mechanisms are in place to anchor the retractor to the spine. So here's an example of a posterior screw shim that gets placed in the posterior blade, and that keeps the retractor relatively stable. You could place the ALL retractor if you need to or not. Here's another model in which they use a tube dish shim strategy in order to anchor the retractor to the spine. And both of these are designed to prevent pull-out of the retractor. And I'd say that I've used most of them in the market, and they probably work like 90%. And then the main issue around safety when you consider lateral, especially at lateral L45, is neurological complications. So when comparing prone to lateral decubitus, they're effectively the same. It's really the operative level, L45, that influences the rate of injury. This is our current strategy around neuromonitoring in the lateral space, triggered EMGs for docking, transcranial, MEPs, and SSEPs in order to stay safe during the work. Hopefully they alert you if there's something going on. But these have been found unreliable at times with false negatives. So in the last 10 years, time has been pounded in our head as being the most effective way to try to prevent an injury. The 20-minute rule is something that's often discussed, 20 minutes or 15 minutes, or I could do a lateral in 10 minutes. And the idea is to try to avoid an injury. But during our early learning curve of prone lateral, we had retractor times that were 30 minutes, 35 minutes, 40 minutes, but patients didn't have an injury. So, that rule didn't really sit well with me. So we did a multi-center study looking at the 20-minute rule, 650 patients, and this graph shows our results. You see injury rate versus retractor time, and you'll see there's 6 injuries on the left, which is less than 20 minutes, and then 6 injuries on the right, which is greater than 20 minutes. So injuries would happen on both sides of the retractor time. Sensitivity was about 50%, and the bar on the right shows the false positive rate. So 96.6% of patients which had a retractor time of greater than 20 minutes did not have an injury. So, I mean, in all, it's not a great rule in order to try to stay safe in the SOAS. So we have to kind of lean on industry a little harder to say, well, we need to be more sophisticated about understanding why injuries happen during lateral. We all know it's because the nerve is traversing through the field. But how do we know what's actually happening in real time? So, Michael had mentioned the transabdominal muscle action potential. There's a lot of interest in studying that right now, and there's also interest around saphenous SSEPs in order to try to, give us real-time feedback of what's happening as opposed to relying on just time alone. So in conclusion, safety and efficacy profile of prone lateral in the last 5 years is there. I mean, it seems comparable to lateral. And there's a resurgence in R&D in order to actively try to find ways to make prone lateral more predictable, answer the issues around patient stability and retractor stability to create positioners and new retractor add-ons or just new retractors. And then, renewed interest or conversations around neuromonitoring to try to find more of a sophisticated method of understanding what's happening in real time. Thank you.